International Congress on Pediatrics. In today's webinar agenda, we will be covering immunology and allergy session. We invite physicians around the world to join us and share their valuable experience with us. This is the third day of our online webinar, and we are happy we were able to perform it in a timely manner. I hope you haven't missed those 2 days, and if so, don't worry, because you have access to recorded session on our website. I am Dr. Azin Qamari, medical doctor from Tehran University of Medical Science, the manager of this webinar. We are so happy to have Professor Nima Rezaei with us. I'd like to introduce today's panelists. We are so happy to have Professor Nima Rezaei with us from Research Center of Immunodeficiency, Universal Scientific Education and Research Network, or USERN, Children's Medical Center, Primary Immunodeficiency Disease Network, Tehran University of Medical Science, on the subject of approach to children with congenital Neutropenia. And Professor Mahdavinia from Allergy and Immunology Division, Department of Internal Medicine, Research Director, Rush Center of Sinusitis, Allergies and Asthma, Rush University of Medical Science, Chicago, on the subject of diet, environment, and microbiome. What is their role in pediatric atopic conditions? Professor Oksana Boyarchuk, Department of Children's Disease and Pediatric Surgery, Ternopil National Medical University, Ukraine, on the subject of allergic manifestations of primary immunodeficiency disease and its treatment approaches. And Professor Alireza Ranjbar, Director of Institute of Interventional Allergology and Immunology, Bonn, Germany, on the subject of molecular pediatric in context of clinical pediatrics today's and tomorrow. I would like to take a moment to thank our speakers, our dearest panelists, for joining us today. I would also like to take this opportunity to thank the Vice Chancellor for Global Strategies and International Affairs, Directorate of International Relations of the Tehran University of Medical Science, for giving me the privilege to patron this important event. And I would, I also would like to thank our dearest audience for joining this event. And I gotta tell you, we weren't here if it wasn't for Dr. Rezaei and Dr. Aghay. Thank you for so much for making this all happen for us. Dr. Aghay wants to talk a few words with you. Dr. Aghay, please, we are all ears.
Thank you very much. I also want to thank all of our lecturers and also audiences for their time. I won't go for each name, but thanks from the executive, on behalf of the executive committee here in Tehran University of Medical Sciences. Thank you for your time, and let's start this wonderful session. Thank you.
Thank you, Dr. Aghay. A few reminders before we get started. This webinar is broadcasting live on the YouTube channel. A recorded version of this webinar will be available on our website. Information about our social media is provided on the chat section. Due to the number of participants, please make sure that you have muted your microphone during the lectures. And if you have any questions, we encourage you to ask them by chat section. Please feel free to ask questions at any point during the presentations using the chat section at the bottom right of your screen. We will reserve time at the end of each presentation to answer your questions. We would do our best to answer as many questions as possible throughout today's event. If you want to receive a certificate of attendance on this Congress, make sure to register on our website and reserve a seat on your desired panel. For our Iranian audience, if you want to receive CME credits, don't forget to participate in the panel quiz in maximum of 2 days on cmequiz.ir. Don't forget to follow us on our social media pages and YouTube channel to stay updated on our next events. And with that, we will open today's webinar. We are very lucky to have with us today Professor Nima Rezaei. Professor Rezaei, we are all ears. Thank you.
Thank you, Azim, for your nice introduction, and thanks, Ehsan, for all you did for the, organizing such an amazing Congress, making international meeting. Okay, so let me share my screen. And I do not know if you can see my slide or not.
We can see your slides, sir, but there is a little problem with your voice. I think you should just change your headset or something like that.
Is it okay or not?
I'm not sure. Let me ask my other colleagues about the voice. Is it okay with you?
Professor, I have your voice very well. Please continue.
Okay. Sorry.
Okay,
just
great.
continue. Thank you.
Okay. Good afternoon, everyone. It's actually my pleasure to present the lecture regarding approach to neutropenia in the 32nd International Congress of Pediatrics. First, I would like to mention some points about the phagocytic system. And as you know, the phagocytic system is the most important part of the innate immunity. And neutropenia, as low absolute neutrophil count, is the most common phagocytic defect. So neutropenia could be defined as low number of absolute neutrophil count with less than 1,500. And we can classify neutropenia to severe neutropenia as neutrophil count of less than 500, or moderate as 500 to 1,000, and mild as 1,000 to 1,500. So if you name a patient with severe neutropenia, it means that the patient has absolute neutrophil count of less than 500. And impaired production, peripheral destruction, and abnormal distribution of the neutrophils could be the reason for neutropenia in affected patients. So if you look at this slide from the textbook of the primary immunodeficiency, which was published a few years ago, at the left, you can see this is the bone marrow, and you can see that the poor myelocyte could mature to myelocyte and then mature to neutrophil in the circulation. And then neutrophil should circulate in the circulation and then do diapetes and get the pathogen inside and digest and then make apoptosis. So please consider that if we have some problem in maturation arrest, it means that at the left side, if we cannot see the myelocyte enough, we will have some kind of neutropenia. But if we have enough neutrophil in the circulation and they have some problems in rolling, it leads to another disease which we name leukocyte adhesion deficiency, or LAD. And in another disease, if we have enough neutrophil could circulate in the blood and then do diabetes and get the pathogen inside, but cannot digest the pathogen. Then other immune system could help the macrophage and make a granulome. So we name the disease as chronic granulomatosis disease, or CGD. So we could see the pathophysiology of disease by this slide. Neutropenia could be classified to two kinds of congenital and acquired neutropenia, and acquired has some what's wrong with the slide? I do not know what happened, but the acquired could be due to the infection, malignancy, malnutrition, immune-related or increased distraction. And so I do not know what happened with the slide. Maybe one of the audience make such shape. So let me just try to see.
I'm sorry, sir. There is some inconvenience with the slides that we are not sure what's the problem with that, because we do not have anyone co-hosted other than the lecturers. So if you can just forget the problem and continue, because I think we cannot do anything more of that.
I just stop sharing and then, share again. So I think the problem is solved now.
Thank you very much.
Okay. So as I mentioned that neutropenia could be classified into two types of congenital and acquired. And the congenital neutropenia could be classified as non-syndromic neutropenia, oculocutaneous hypopigmentation and neutropenia, pancreatic insufficiency plus neutropenia, combined immunodeficiency, metabolic disease, bone marrow aplasia, and other syndromic neutropenia. So they could be as a, new classification for congenital neutropenia. As I mentioned, my talk is about congenital neutropenia, but if you look at this slide, you can see that infection associated with neutropenia could be due to bacterial infection, some viral infection, or malignancies like leukemia, lymphoma, or malnutrition like copper deficiency, B12 deficiency, or folate deficiency, and some drug-induced neutropenia and some other conditions. So there are some diseases which could be associated to acquired neutropenia. And if you look at this slide, in subcategory of disease, when we mention non-syndromic neutropenia, it could be either severe congenital neutropenia, which could be as autosomal dominant like GP1 deficiency, or Elaine as a sporadic deficiency, or severe congenital neutropenia in autosomal recessive form, which is the Castman syndrome, which could be due to HAX1 deficiency, X-linked neutropenia as a WASP mutation as X-linked neutropenia, and cyclic neutropenia. In the category of oculocutaneous hypopigmentation or albinism with neutropenia, we could mention some diseases like Chediak-Higashi syndrome, Griscelli syndrome type 2, Hermann-Podlak syndrome type 2, and P14 deficiency. In pancreatic insufficiency, I can name Schwachman-Diamond syndrome as an immunodeficiency associated with neutropenia, but we have Pearson-Marrow syndrome, which is not immunodeficiency, but again could be associated with congenital neutropenia. In the category of combined immunodeficiency, CD40 ligand deficiency, WHIM syndrome, which is abbreviation of the WART, hypogamma, immunodeficiency, and myelokathexis, and neutropenia, reticular dyskinesia, and cartilage hair hypoplasia are all are combined immunodeficiency associated with neutropenia. And in metabolic disease, I can name glycogen disease type 1B. We have also some other diseases like beta-2 deficiency or monomax syndrome and dyskeratosis congenita. And in syndromic neutropenia, I can mention some diseases like G6PC3 syndrome, Cohen syndrome, Barr syndrome, and poikiloderma with neutropenia. So these are, there's some subclassification of congenital neutropenia. And if you look at this slide, I just mentioned some congenital neutropenia which are all associated with primary immunodeficiency diseases. So I start with severe congenital neutropenia, also known as Castman syndrome in autosomal recessive form. As I mentioned, the patients usually have severe neutropenia, persistent severe neutropenia. So absolute neutrophil count is less than 500. They have increased susceptibility to infection, early onset of bacterial infection. And if we look at the bone marrow slide, we will see that they have some maturation arrest from promyelocyte to myelocyte. These patients usually suffer from some abscesses in different organs, cutaneous infection, pneumonia, oral ulcers, omphallitis, and otitis media. And they could also suffer from some diarrhea, respiratory infection, and mucocutaneous infection during the course of disease. So there are several gene defects associated with neutropenia, like Elaine or ELA2, GFI1, which is autosomal dominant, HAX1, VPS45, JAGM1, G6PC3, and WASP, which are some genes which are associated with severe congenital neutropenia. So this is one of the historical papers which we had the chance to publish in 2007. And as I can mention that the Castman syndrome or autosomal recessive form of neutropenia was introduced by Dr. Castman in 1956. But the gene was discovered 5 decades later, which was a collaborative study, and I'm very proud to be a part of this paper, which was published in Nature Genetics. So if you look at, how we could, make some progress in, discovery and make some progress in treatment of the patient, it could be due to, some kind of international collaboration. So again, if you look at this slide, we will see that the HAX1 and Elaine, those could, accelerate apoptosis as in myeloid progenital cells of the patient. And I mean, after the historical paper, we realized that the HAX1
Dear Dr. Rezaei, we lost your voice. I think oh, okay. Your voice is back. Your voice is back. Okay.
Okay, sorry. So
no problem.
Sir, like some neurological
sorry.
we publish this paper in Blood.
I think you are facing some internet inconveniences. If I interrupt you, I will apologize for if I will interrupt you because of that. Okay. So let's continue.
That's perfect. That's perfect.
Okay.
So can you hear me?
Yeah. Now it's okay.
Okay. Sorry about that. So I mentioned that, for example, we had a patient with some kind of convulsion and epilepsy, and we found that the case has some kind of neutropenia as well. So it was just a coincidental, association of HAX1 deficiency and neurological disorder. But later on, we realized that, the HAX1 has 2 transcripts, and we published this paper in the Blood journal. So this is a case with some kind of recurrent pneumonia, recurrent diarrhea, and oral candidiasis. But if you look at this story, this case was initially underwent some cardiac surgery by a cardiac surgeon due to AST, atrial septal defect. And later on, the patient was, affected by some kind of rectovaginal fistula. So it was not a pure neutropenia. If you look at the CBC of the case, you can see that the absolute neutrophil count of, the cases were moderate to, severe neutropenia in all conditions. And if you look at this table, so you can see that, we have several gene defects and we have several, clinical manifestations. So I would like to emphasize that we should put all the data on the desk to make the best diagnosis. So if you look at it here, you can see that the patient has some kind of cardiovascular system disease, so this kind of disease. And if you look at, come down, and you can see that the patient has some kind of congenital neutropenia, has some skeletal problem, has some delayed dysmorphic, skin hair, so orogenital system malformation, which is unique for other, diseases. And the diagnosis of G6PC3 syndrome was made for this patient. And we found the mutation in this case, and we had the chance to publish this paper in the New England Journal of Medicine as a new syndrome with congenital neutropenia and some kind of, congenital heart disease and orogenital malformation. And just a few years ago, we just described another gene defect, JAGN1 deficiency, which is also, again, associated with some kind of congenital neutropenia. So these are all about congenital neutropenia. But we visit some patients which has some kind of periodic neutropenia. They have, about 3 to 6 days of neutropenia with the cycle of 3 weeks, 21 days. And during neutropenia, they could also have some kind of cyclic anemia and cyclic monocytopenia as well. And we found that ELANE or ELA2 could be, responsible for cyclic neutropenia. Another disease is oculocutaneous hypopigmentation or albinism with immunodeficiency. And there are some diseases like Chediak Higashi syndrome, Grishali syndrome type 2, Hermosi-Paddock syndrome type 2, P14 deficiency, Poly-D deficiency, and VC syndrome. They are all, associated with neutropenia and some kind of albinism. So just 2 decades ago, any patient with some kind of albinism just resembles some diseases like Chediak Higashi syndrome. But later on, we realized that, for example, a disease like Grishali syndrome type 2, which you can see this in a slide, with silvery hair, eyelash, and eyebrow, could be, even more common in some, region with consanguineous marriages. Again, if you look at this table and see the difference between these diseases, you can see, for example, this row. For example, in Chediak Higashi syndrome, they have disturbed regular melanin. But in Grishali syndrome type 2, they have large irregular melanin. So there is no need to, do exome sequencing for all the patients. You could do some simple tests like checking the microscopic hair shaft of the patient. In a patient with Celiac Higashi syndrome, they have giant granule, giant cellular granule. So if we just check the peripheral blood smear, we will find that they have giant granule, which is, unique for Celiac Higashi syndrome, and it's rare for other conditions. So this is the hair shaft of the disease. At the right side, you can see a contour. This is the Celiac Higashi syndrome with irregular, and this is the Griscelli syndrome with some, melanin at the middle of the hair shaft. Another disease is WHIM syndrome. This is what? Hypogamma, immunodeficiency, and myelocataxia. But we should be very careful about the diagnosis because some of the patients are not old enough to, develop what. So I have, some cases who had some kind of neutropenia because of myelocataxis, infection, and some kind of hypogamma. So I just criticize this name as WHIM syndrome or HIM syndrome or CXCR4 deficiency as a new, genetic name for such kind of phenotype. Another disease is Schwachman-Diamond syndrome, which we usually, know these cases with some kind of pancreatic insufficiency and some kind of neutropenia. They have some kind of skeletal abnormalities like pectus ductus, some growth retardation, some dental caries, neurodevelopmental delay, and hepatic dysfunction. And if you just do, sonography of this case, we will find that they have some white pancreas because the pancreas is, affected because of the lipomatosis. So it is very, essential to do sonography and see the defect in pancreatic, exocrine pancreatic insufficiency in those patients. Another disease is cartilage hair hypoplasia. It's clear from the name that they have some short limb, short stature, some metaphyseal chondrodysplasia. They have hypoplastic hair. They have macrocytic anemia, and they have some laxity in the ligaments, and they have also some kind of neutropenia. They are also predisposed to some kind of cancer as well. So if I plan to just list the diseases with other phagocyte defect and associated with neutropenia, I can also mention some diseases like glycogen storage disease type 1b, BAS syndrome. They have some kind of heart failure, some skeletal myopathy, cognitive impairment and growth retardation. Cohen syndrome, they have some kind of hypotonia, obesity, and retinopathy. And poikiloderma with neutropenia, which could, be associated with some kind of telangiectasia as well. And other PIDs associated with neutropenia, I can mention some kind of CD40 ligand deficiency, which is X-linked form of hyper IgM syndrome. So this is some kind of immunoglobulin class switch recombination deficiency, which means that IgM cannot class switch to IgG and IgA. So IgG and IgA are low, but IgM could be normal or increased. So that's why we mentioned the disease as hyper IgM syndrome. And the CD40 ligand deficiency is usually associated with neutropenia as well. Reticular dysgenesia and dyskeratosis congenita are two other diseases, two other primary immunodeficiency diseases associated with neutropenia. Glycogen storage disease type 1b, BAS syndrome, dyskeratosis congenita, Cohen syndrome, poikiloderma with neutropenia, and reticular dysgenesis are some other diseases. So how we could make suspicious to neutropenia? So it's, very simple. Just, checking the CBC, just regular CBC. And if we find that the patient has severe neutropenia, we should repeat it at least, 3 times for 6 weeks to 6 weeks to see that if this is the cyclic neutropenia and or severe neutropenia, severe persistent neutropenia. And early diagnosis and appropriate treatment are the keys to make the, early diagnosis and do appropriate treatment for this patient. So we should exclude secondary neutropenia, as I mentioned at the beginning of my talk, and we should check the bone marrow to find out if the case has, maturation arrest or not. We should do some immunological studies to exclude other immunodeficiency diseases associated with neutropenia. And then after making the diagnosis, there is a new need to make the treatment. So GCSF, granulocyte colony stimulating factor, could be the best diagnosis protocol for the patient with severe neutropenia. And we should be, also consider some antibacterial or like cotrimoxazole or antifungal if necessary. And bone marrow transplantation or hematopoietic stem cell transplantation might be needed if the patient do not respond to G-CSF, or if the patient continues severe bacterial infection despite receiving G-CSF, or the patient is getting complicated with AML or myelodysplasia. These are the indication of the hematopoietic stem cell transplantation for the patient with neutropenia. So there's no need to do, hematopoietic stem cell transplantation for all the patients with severe congenital neutropenia. And for the follow-up, we should make follow-up at least twice per year to check the CBC. There is a need to check the dental cavity and also anus lesion because both regions are full of pathogen, and we should be very careful about it. Checking CBC every 3 months and checking, bone marrow because of, to check the morphology and cytology because they are, prone to AML or myelodysplasia might be needed. And in some cases, G-CSF receptor analysis might be needed because they have, there's some reports that, G-CSF receptor could make some mutation, and then in this case, EMT might be needed. So if you look at this slide from the top to the left, this is some kind of infection. First, we should check the CBC. If the patient has severe persistent neutropenia, we should do approach to congenital defects of phagocytes, as I mentioned, as syndromic or non-syndromic, as I mentioned in my presentation. But if the patient has normal absolute neutrophil count, absolute neutrophil count, we should check NBT or DHR, nitroblue test, or dihydroramine test to exclude CGD or chronic granulomatous disease. And if it's intact, we could check chemotoxic test or some other, flow cytomarker like CD18 or CD15 for LAD type 1 or LAD type 2. And there are some other motility defects in this slide as well. So I'm very pleased that I'm working in the Children's Medical Center Hospital, the Pediatric Center of Excellence in Tehran University of Medical Sciences. And we have also a research center, the Research Center for Immunodeficiencies, which we could do some genetic diagnosis, perinatal diagnosis, and genetic counseling. And we could do mutation analysis of HAX1, ELANE, CD40 ligand, G6P, VAS. The genes that I mentioned in my slide could be, checked in the research center in the Children's Medical Center hospitals. So what I mentioned is from the textbook of primary immunodeficiency diseases. This is the second edition of the book, and I would like to emphasize that when I edited this book in 2008, it was only about 150 to 200 different primary immunodeficiency diseases, but nowadays there are more than 400 diseases. It means that during less than 1 decade, the number of primary immunodeficiency diseases are increased more than twice. So it highlights that how much is important to keep ourselves up to date to all the diseases, all the gene defects, all defects, and all clinical manifestation of the patient. So I just briefly mentioned about the approach to neutropenia, and thank you for your attention. If you have any question, I will be more than happy to answer.
Thank you, Professor Rezaei, for an enlightening presentation on approach to children with congenital neutropenia. We appreciate having this mysterious area clarified. Next, we will have Professor Mahdavinia to tell us about diet, environment, and microbiome. What is their role in pediatric atopic conditions? Professor Mahdavinia, hi, thanks for joining us today.
Hello, thank you so much for inviting me. It's a pleasure. So as I said, I appreciate if you could play the recorded.
Hi, Professor. Yes, we are going to play your pre-recorded presentation. Our team is working on it. Thank you very much.
Of course. I'm an allergist immunologist and a physician scientist at Rush University Medical Center. Thank you very much for inviting me to give this talk today. It's an honor to participate in your great congress. So today I'm going to talk about how changes in the diet, environment, and the gut microbiome in early childhood can predispose a child to atopic and allergic conditions. Next, please. The learning objectives will be to focus about learning what is hygiene hypothesis, how diet can influence the gut microbiome, and to understand the link between the changes in the environment and predisposition to allergy in early childhood. Next, please. Hygiene hypothesis was this very interesting, genius idea that was put forward about 2.5 decades ago, that microbes are good for the health of human beings and are protective against allergic diseases. And this protective effect seemed to be coming from living in a farm. The idea came from an observation in Switzerland when they compared the children who were raised in Swiss Alps in a farm in a situation very similar to the picture you're seeing. So an infant is being raised inside a barn, very close to the animals and in proximity to all the microbes in the environment. And they compared the rate of allergic diseases in those children to those with the very similar genetic background that were raised in Zurich, which is a modern industrial city. The rate of allergic diseases was almost 3 times in children who were raised in Zurich. So the idea was that maybe being raised in a farm is protective against development of this type of conditions. Next, please. And then the next studies started looking at what actually changes with moving from a rural area to an urban industrial area is the microbiome, which is the colony of all the bacteria and other microorganisms that live within and on the surface of human being. And it appears that they're actually a very important part of our immune system, and they have a role in protecting us against allergic diseases. But their development in human takes about 3 years from the time that the infant is born, and that is dependent on the individual's exposure to surrounding environment. So at some point as humans, we forgot that we are animals too, and we need to live in nature and in close proximity to the microbes in the nature. Next, please. And the next set of experiments and research after that started looking to see what are the bacteria in the farm that are protective. And actually in mouse models, they could find at least 3 specific species of bacteria that in the mice could grow from a farmland environment in the gut of a mice and protect them against development of severe allergic conditions. Next slide, please. The gut microbiome, so the group of all the microorganisms inside the intestine of an individual, is proposed to be possible contributor to this increase. And so at that point, we understood that the diversity of this microbial exposure is inversely associated with the development of allergic diseases, meaning that we need to be exposed to not only specific bacteria, but a very large quality and quantity of the microorganisms to develop the healthy gut microbiome. Next. So these are observations that have been seen throughout the Western, at least, countries. And following that, we're seeing the same trend in the whole world, that all atopic conditions are in rise. So in the past 3 decades, there have been almost a doubling in the rate of food allergy, anaphylaxis related to food or drug allergy, even rate of eczema, asthma, and allergic rhinitis. And it is now thought that the environmentally induced change in the commensal microbiome in the gut is what's driving this rapid increase in the allergic responses. And that, in a nutshell, is what hygiene hypothesis. So we change the environment, we change the way we live, we decrease our exposure, hence we were predisposed to allergic diseases. The focus of my line of study was how the changes in the diet can affect the gut microbiome in a way that predisposes a child to allergic diseases. So in this picture, as you can see, these children on the left side of the picture are living in a very natural setting. They're eating a fruit picked from a tree as they are going around without washing their hands and running and active and eating those type of fruits and diet. On the right is the modern child that's in front of the TV, not active enough, while eating things that are called food, but they're far from foods, highly processed material from food sources that by that point do not look like anything like food anymore. And that unfortunately has become the mainstay of everyday diet of most children throughout the world. So we wanted to see that shift in the diet, how can that impact the gut microbiome? Next. And in this study, we actually chose to study an African population. The reason was, I had a personal reason. When I was a PhD student, I was a PhD student in genetic epidemiology, and my main supervisor always told us that if you want to answer a question, you have to go to the source of where that change happened. And African continent is where human race was born. So it was interesting to look at the children who were still in Africa, which are highly protective against any type of allergic disease. The rate is very, very low in most African parts, especially in South Africa and the part that is rural and untouched. And we wanted to compare those to the children from African ancestry, like African Americans, who are actually have the highest rate of allergic diseases and the most severe types of allergic diseases. So we hypothesized that probably there's something in their diet and environment that is keeping their allergic genes in check for centuries. And it would be very interesting to find those keys, because that could be now implemented for the whole world. Next, please. And in certain areas of Africa, people still live in very close daily contact with animals and within the nature. So determining those factors would have been really interesting for our studies. Next. So we collaborated with Cape Town University in South Africa and looked at the children, a group of children from a certain tribe in South Africa that live in remote rural district of the Eastern Cape. We had a group of them that had developed atopic dermatitis. So this was very interesting because the atopic dermatitis, which is abbreviated as AD in these slides, is very rare in that area. So it would be very interesting to see what has happened to that children in that villages that they developed eczema, and compare them to a group of controlled children that we recruited. Actually, we had to stay in tents in that area because there was no place to stay beside the houses that they have made completely from clay and wood, as you can see in the picture, and recruited these patients for our study. They're children from rural Cape area, so we had 83 children altogether, 36 with atopic dermatitis and 47 controls. Everybody was tested for a panel of food and environmental allergens. And the first observation was that atopic dermatitis was significantly associated with food sensitization, but not with allergic rhinitis. So most of these children with eczema also had evidence for being sensitized to food. None of them were food allergic. So having a positive test does not necessarily mean that child is allergic to the food. As long as they're tolerating it, there's this mechanism, immune mechanism we call tolerance, that we know it's active. But that's the first step to development of food allergy. So that's alarming that these children with eczema, even in that rural areas, are significantly at higher risk of food allergy now. But the interesting part was that there was no link to allergic rhinitis, which we see within the rest of the world. Next, please. And we had these dietary intakes, a very detailed dietary intake survey from few days of what they exactly had eaten, and could come up with collaboration with the dietitian that what are the exact components of the diet that's different between the two populations. So the children with atopic dermatitis group had significantly higher daily consumption of total sugar and saturated fat compared to the control children. These are children from the same exact villages. So really there's not much different, and the food is not coming from outside. So that means that within the same diet, if you go really high on the total simple sugar and saturated fat, the rate of allergic diseases increases, which was a very actually interesting observation, because most of the previous studies were comparing children from two different societies and looking at their diet, but within the same society, we were reproducing the same data. And another interesting point was that breastfeeding didn't have an impact on eczema. Next, I'm going to talk about the microbiome analysis on this group. So this is a simple figure showing how microbiome analysis is done. We start with the microbial community samples. We amplify those to generate multiple strains of each bacteria we have, and then generate these lines, compare that to a national database to see what each bacteria group belong to, and then create this phylogeny or relative abundance figures that you can see on the bottom. So I'm going to talk about bacteria. I'm actually talking about that figure down there when we get to that slide. Next, please. And the bacterial classification starts with the kingdom of bacteria. And after that is phyla, which is the first grouping. We come down, get to the genus and species. 16S microbial analysis are best up until we talk about the genus of bacteria. We could talk about species, but whenever I talk about the species, we have double checked that with specific PCR to make sure that is the bacteria that we have observed. Next, please. Okay. And this slide shows you what is diversity in microbiome when we talk about. So when we talk about richness, we're simply saying how many types of bacteria are in this sample we have. Community A has 6 samples, very simplified, 6 bacteria, that's the richness. Evenness is how even this number of bacteria are distributed, but Shannon and Simpson index, that are the diversity indices, are actually mathematical models based on these differences. So when somebody talks about diversity, this is a multifactorial mathematical number we're talking about. And the diversity being higher is always better for a bacterial community. Next, please. All right, so I'm going to jump to the most important finding in our study. So when we compare the rural atopic dermatitis children to controls, we found one specific bacteria called Prevotella copri that was significantly reduced in children with atopic dermatitis. And in comparison to that, there was another bacteria called Bacteroides vulgatus that was significantly higher in children with eczema. This is the result of months of study looking at thousands of species and genus of bacteria. And this was the one that after correction for multiple analysis still stood out. So at this point, we were sure that P. copri is a key bacteria that is protective in these children against eczema. Next slide, please. And interestingly, we understood that the high simple sugar content in the diet was associated with lower bacterial diversity. So after chart, we knew it was associated with eczema, and we understood that it was also associated with lower bacterial diversity. Next, please. And interestingly, P. copri itself was associated with lower intake of fat. So high saturated fat intake was associated with lower abundance of P. copri in these children. Next. And I'm just showing you one of the sample of analysis. These are all the factors that we took into account. This is actually 1/10 of the factors that we took into account to coming to those previous slides that showed you that the most important ones was P. copri and increased saturated fat in the microbiome analysis. Next, please. Okay, so the next set of studies was, after we understood that P. copri is important, is linked to diet, we expanded our study and recruited a group of children from urban Cape Town, same exact tribe of children who were raised in an urban setting and had developed eczema or not. And we compared their microbiome to the children from rural area. So as you can see, the gut microbiome differed significantly between rural and urban children in this South African study. But the interesting part that these are completely genetically identical children that now develop significantly diverse microbiome depending on where they are raised. Next study, please. Next slide, please. Thank you. And these are the 4 groups. So we had also children with eczema or atopic dermatitis from Cape Town. And the 4 groups, microbiome stands in 4 different discrete groups. So having eczema shifts your microbiome towards the left side, and they're living in an urban environment shifts your microbiome to the higher side in this slide. And this was a very important finding at this point, that urban environment changes the microbiome, and there's a subgroup of changes that result in atopic dermatitis. Next, please. And the relative abundance of P. copri, as you can see here, significantly is reduced in urban children. So just living in an urban environment, you lose that protective bacteria in the gut. Next, please. We corrected our analysis for the prevalence of Prevotella as a genus in general, because Prevotella is linked to a vegetarian diet. And we wanted to know if urban and rural children had a completely different diet. And it seems that it's not, because the distribution of the genus are very similar, but it's that specific P. copri that reduces in the rural children of Cape Town. Next slide, please. So in summary, toddlers with atopic dermatitis had significantly higher sugar and fat. Higher sugar was associated with decreased diversity of gut microbiome that is itself associated with atopic dermatitis. High fat intake is associated with decreased relative abundance of P. copri, which is associated with lower risk of atopic dermatitis. And the rural children in South Africa have significantly lower rate of allergic diseases, including atopic dermatitis. And we also understood that the rural diet had less fat and sugar, and the gut microbiome was more diverse and had more P. copri. Next slide, please. So the next study, we recruited a group of African children with similar ancestry from South African children that have were born and raised in Chicago, and compared their gut microbiome to the ones in South Africa. And so ASA is African, South African, because as you know, South African have white population too. So we call them ASA in these studies that we're calling African Americans, AA. As you can see off the beginning of the study, there's significant further shifts. So African American children are at significantly higher risk for development of allergic diseases. That's a fact. We see it in Chicago. They're the highest risk population, but also compared to the South Africans, their gut microbiome is completely lacking the diversity needed in a child's microbiome. Next slide, please. And the relative abundance of Prevotella is very low. So except 4 children, the rest of them had almost none Prevotella. This is very, very alarming for anybody who studies microbiome. So this is a very important genus of bacteria protecting children not only against allergic diseases, but all inflammatory diseases that's almost disappeared from the gut microbiome of African American children. Next slide, please. And then we looked at the more in-depth analysis to see really what's driving the gut microbiome changes, and Prevotella in any type of analysis we did stood really high. That's actually an important bacteria that has been lost in the gut of these children. Next slide, please. And that's more going to the species of bacteria. So this is the second type after the 16S. We did a more in-depth analysis. And as you can see, the first line called OTU12 Prevotella copri again stood out. So these key bacteria that we had understood that is a very important key protective bacteria in the gut microbiome of toddlers is lost in African American children. Next slide. And this is not surprising. So in this group, we have compared the children from Africa, South African, rural, urban with African Americans. If you come down at the bottom, you can see the rate of food sensitization is almost double in African American. Then the allergic rhinitis is almost 10 times in African American children compared to rural South African, and more than double in urban. And the rate of wheezing, which is the predisposing asthma condition, which is 0 in rural South Africans, is 17% in urban African American children. And this is not surprising in the context of the microbiome. So next slide, please. Yes, thanks. So in this paradigm, you're saying that for a child to develop atopic diseases and especially allergy, there is a component of microbiome that's necessary on top, a healthy diet that's necessary that sort of protects the inflammatory cascade, shift them toward the tolerance, which is you see in the left side. But once, can you press next? Oh, thank you. So once that is blocked because of the shifts in the diet or environment, the PCOP is blocked, then that shifts to development of atopic dermatitis and food allergy in children. Next slide, please. So there are more studies that we did, and I'm going to go through this a little faster. We looked at the environment and what's in the dust in the houses of these children at this point. So same children, not exact same children, but same groups of children. We looked at their dust environment. We actually vacuumed where they sleep and looked at the microbiome in the environment and compared those 4 groups. Next, please. And as you can see, the urban versus rural houses had significantly different microbiome in the diversity index. Next, please. And they beautifully disperse in the Bray-Curtis matrix. Almost, there's no overlap of what is in the microbiome of a house of a child in rural area versus of the microbiome in the house of a child living in the urban Cape Town city. Next, please. And we could actually discover 3 specific species of bacteria that their relative abundance was linked to the atopic dermatitis and were significantly reduced in urban area, meaning those protective bacteria in the environment were very important. And once they decreased, the chance of development of allergic diseases significantly went up in these children. Next, please. And that's the 4 groups. Again, now this is atopic dermatitis versus control children. So those who had atopic dermatitis that are red, as you can see, group different from the ones who did not have, who did not have any allergic condition. Next, please. And this type of secondary analysis could show us that there's 2 main Clostridia bacteria that are in the environment and they're key in protecting against eczema. Next, please. So in summary, we found the increased levels of Rhominacoccus and Lachnospiratia in rural house, and we found increased levels of Rhominococci in the homes of healthy rural children. So it is linked to eczema, and it is linked to living in the urban setting. Next slide, please. So we could move forward one more. Next, please. So Clostridia bacteria might be the link of environment, gut microbiome, and allergy. And previous studies have shown actually Clostridia is important in keeping the inflammatory pathway in check. So and our set of studies are showing that the increased level in the gut is associated with increased level of them in the environment. And once the house has decreased level of this Clostridia, the chance of allergy increases. Next slide, please. Can you press next so the rest of the, thank you, and next please, awesome. One more time. All right, so not only shift in the gut, through changes in the microbiome, if the diet changes can shift the child to atopic condition, there are certain bacteria in the house dust that belong to the Clostridia family that are very important as protective factors, and once that block, that shifts the child to development of atopic dermatitis. Next, please. And with that, I would like to thank you again for listening to me, and I would take any questions that you might have.
Thank you very much, Professor Mahdavinia, for your great, spectacular presentation and the useful information you gave us. Just one question I wanted to ask you. Up to what age can we expect nutrition to be able to prevent atopic dermatitis?
So we believe that this is through infancy most likely, and maybe we have a chance until age of 3, but after that, shifting the microbiome by dietary changes is extremely difficult because the gut develops something that we call microbiome memory and sort of sticks back to how it was even after dietary changes.
Thank you very much, Professor, for your answer, and thank you again for your spectacular presentation.
Of course.
Thank you. So we shall proceed to discussion with Professor Oksana Boyarchuk, if I pronounce it in the correct way. Professor Boyarchuk, could you please define the allergic manifestation of primary immunodeficiency disease and its treatment approaches? Thank you. Professor, we don't have your voice. Yes, thank you.
Do you hear me? Do you see?
Yes,
Good
thank
evening.
you.
Good evening, dear colleagues. Thank you for the invitation for participate in 32nd International Congress on Pediatrics. My name is Oksana Boyarchuk, and I am from Ukraine, I.Horbachevsky Ternopil National Medical University. And I would like to present my report, Allergic Manifestation of Primary Immunodeficiency Diseases and its Treatment Approaches. As we know, primary immunodeficiencies are a group of diseases caused by genetic defects, and they are characterized by recurrent infections and certain immunological phenotype. Currently, we know more than 450 primary immunodeficiency, and during last 30 years, the number of primary immunodeficiencies increased from 20 to more than 400 in Bonn errors. And as we say about primary immunodeficiency, we mean firstly infection. But besides infections, primary immunodeficiency is also characterized by autoimmunity, by allergy, and by malignancy. And according to the 2019 update on the classification from the International Union of Immunological Society Expert Committee, primary immunodeficiency are classified into 10 major groups. And they include combined immunodeficiencies with syndromic features, predominantly antibody deficiencies, disease of immune dysregulation, congenital defects of phagocytosis, defects of innate immunity, autoinflammatory diseases, complement deficiencies, phenocopies of inborn errors of immunity, and genes that cause bone marrow failure. Allergic manifestations in patients with primary immunodeficiency characterized by eczema, eosinophilia, increased IgE levels, asthma, and other allergic manifestations. And allergic manifestation occurred in such groups of primary immunodeficiencies as combined immunodeficiency and firstly in patients with DOCH deficiency and Oman syndrome, in patients with some autoinflammatory disorders, in patients with antibody deficiency, in patients with immune dysregulation, but most often allergic manifestation occurred in patients with combined immunodeficiency with syndromic features. And combined immunodeficiency with syndromic features includes group of hyper IgE syndromes, and they consist of 10 syndromes or 10 diseases. Autosomal dominant hyper IgE STAT3 deficiency or DOCH syndrome, interleukin-6 receptor deficiency, interleukin-6 signal transducer deficiency, ZNF 341 deficiency, autosomal recessive hyper IgE deficiency, ERBIN deficiency, Lis syndrome, Normal-Nizerton syndrome, IgM3 deficiency, and hear me because unstable internet. Do you hear me? Okay. Autosomal dominant hyper IgE syndrome or STAT3 deficiency or DOCH syndrome is well known, and allergic manifestation in this syndrome is well described. But DOCH syndrome is not only atopy, it's characterized by triad. And this triad include recurrent staphylococcal buoyance or all staphylococcal abscesses, pneumonias that develop post-infection pneumatoceles, and extreme elevation of serum IgE. But besides this triad, block syndrome is characterized by non-immune features, and as of all, characteristic facial abnormalities such as facial asymmetry, hypercolorism, broad nose, gipsed eyes, and prominent forehead. It's also characterized by dental abnormalities such as fail to lose their primary teeth, and these patients have two sets of teeth simultaneously, as we can see in this picture. These patients are also characterized by abnormalities of the skeleton and connective tissue, such as osteoporosis, scoliosis, fractures, and hypermobility. They also can present with vascular abnormalities. IgE syndrome or block syndrome, it's characterized by immunologic characteristic and non-immunologic characteristic. And frequency of non-immunologic characteristic is very high and presented mainly by allergic manifestation. And as we can see, eczema occurred in all patients, and serum IgE more than 2,000 presented in more than 90%. Eosinophilia is also very often. Besides this allergic manifestation, these patients also present with boils and with, as we mentioned, recurrent pneumonias, mucocutaneous candidiasis, and increased incidence on lymphoma. Non-immunological characteristics are characteristic face, retained primary teeth, fracture, scoliosis, and other syndrome. I would like to present our first case. This is male, 9 years old, newborn period with omphalitis. At the age of 1 month, sepsis with pneumonia, enterocolitis, omphalitis, pyodermia. At the age from 6 months to 2 years, he had 3 episodes of pneumonia. Since 2 years, recurrent cold accesses every 1 month, atopic dermatitis since 3 months of age, and at the age of 6 years, he had fractures. His IgE level was 8,000, and IgG and lymphocyte subpopulation was without significant changes. And taking into account sepsis, recurrent pneumonia, recurrent cold accesses, atopic dermatitis, fractures, high IgE level, hyper IgE syndrome was diagnosed. And at the age of 16 years, his IgE level was 59,000, and genetic testing revealed mutation in STAT3. Treatment options included antibiotics to treat infection, imidacloprid, sulfamethoxazole, and ciprofloxacin, and topical medicine for skin rash, macrolimus. In 2014, autosomal recessive phosphoglucomutase 3 mutation was described in the literature, and it was linked to atopic, immune deficiency, autoimmunity, and neurocognitive impairment. And as we can see, all these patients had allergic manifestation. This publication described 2 families and 8 patients, and all these patients had severe allergic manifestation. allergic rhinitis, food allergy, asthma, and atopic dermatitis. Besides that, all they were presented with recurrent infections, pneumonia, otitis, staphylococcal skin infection, Epstein-Barr virus infection, and warts and other infections. Besides that, all these patients were presented with high IgE level, and it counted in thousands, from 5,000 to 27 and 35,000 was IgE level. Sorry. And besides immunological or allergic manifestation, and besides recurrent infections, these patients were presented with neurological manifestations, such as low IQ, developmental delay, dysarthria, ataxia, hearing loss, central nervous system myelination defect, abnormal EEG, seizure, and hypotonia. They were also presented with connective tissue disorders such as scoliosis, degenerative disc disease, dilated aortic root, microcephaly, esophageal tract, and hematologic pathology such as Hodgkin lymphoma, hemolytic anemia, and neutropenia. Recurrent respiratory tract infection in this patient leads to bronchiectasis and chronic respiratory failure. I would like to present our second case, male, 17 years old. It's presentation. He also presented with atopic dermatitis of age, asthma since 2 years. The features such as a flat or sunken appearance of the middle of the face, mid-face hypoplasia, micrognathia, full lips. The patient is presented with intellectual disability and delayed development. He has seizures and herpes virus 6 and hypervirus 7. He also presented with autoimmune thyroiditis and arthritis. He had a high level of anti-nuclear antibodies, and his IgE level was 14,000, and also low NK cells was seen. And taking it into account his clinical picture and mutations that were revealed, IgM3 deficiency was diagnosed. The next is Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is X-linked recessive disorders, and it's also very well described in the literature. It's characterized by a triad, and eczema is one of the signs of this triad, and it's okay in 80% of cases, and it can be mild to severe. The next signs is thrombocytopenia, and with a small size of platelets, and thrombocytopenia leads to bleeding, bloody diarrhea, petechia, and bruising, and immune deficiency, the set signs in these patients, leads to recurrent bacterial infection, cytomegalovirus infection, herpes simple infection, and Epstein-Barr virus infection. These patients also characterized by autoimmune disorders and they have increased risk of cancer, especially lymphoma. They are presented with a high level of IgA and IgE, and 30% presented with eosinophilia. The treatment option for this patient included hematopoietic stem cell transplantations and gene therapy. The next syndrome is DOCK8 deficiency, or formerly was known as autosomal recessive hyper IgE syndrome, and it belongs to combined immunodeficiency, characterized by recurrent infections, allergies, and cancers. Recurrent infections in these patients presented as respiratory tract infections that lead to bronchiectasis. Skin infection presented as herpes simplex virus infection, human papillomavirus, and molluscum contagiosum, and often they are complicated by Staphylococcus aureus and Candida. Allergies in this patient presented as eczema, food allergies, asthma, and other allergic symptoms. They can also can have skin cancer, lymphoma, a cancer of a lymphatic system. Laboratory findings in these patients included high IgE levels, hypo-IgM, and B-cell lymphopenia, and eosinophilia. And I would like to present also our set case, boy, 6-year-old. This is patient, and this is photo from the archive of Anna Hilfanova. And these patients were presented with severe eczema, all body surface was affected, and eczema was with lichenification, excoriation, intensive itching, and severe eczema was presented from 1 month of age. As we can see, the patient have dysplastic ears, short, thick nose, rough features, and large tongue. He was also presented with perianal warts and onychomycosis. 2 sets of teeth, and they were affected by caries, and during first year of life, recurrent infection, pneumonia, oral candida, stomatitis, otitis were seen. And from the age from 4 to 6 years, he twice was presented with sepsis, recurrent pneumonia, and polyarthritis. Osteoporosis, fractures also occurred in this patient. Laboratory findings included hyper IgE level 16,000, hyper IgA, and a low level of IgM. Eosinophilia 30%, and lymphopenia. Genetic testing revealed DOCK8 homozygous mutation. Treatment options for these patients included antibiotics, antifungal treatment, intravenous immunoglobulins. Omalizumab was used with permanent effects, and only hematopoietic stem cell transplantation have a full effect and recovery. The next question: how we can to distinguish hyper IgE primary immunodeficiency from atopic? How we can put together this puzzle? First, on all allergic manifestation in patients with primary immunodeficiency characterized by early onset of eczema. Then the combination with early onset of infection and infection may worsen with age and lead to bronchiectasis and other complications. Then we should look for other signs of primary immunodeficiency, such as autoimmunity and malignancy. Besides that, allergic manifestations in patients with PID very frequent combined with non-immunological features such as facial abnormalities, skeletal abnormalities, neurological impairment, connective tissue disorders, and others. Allergic manifestation in patients with PID is characterized by very high level of IgE, and it counted in thousands. Besides that, laboratory findings such as lymphopenia, low IgA, IgM, and poor vaccine antibody responses may be also helpful in diagnosis. Some authors present algorithm for primary care physicians. When we have eczema that combined with recurrent infections and elevated serum IgE, we should think about primary immunodeficiency. In the case of failure to thrive, severe food allergies, and central nervous system findings, we should think about DOC8 immunodeficiency. In the case of skeletal abnormalities, pneumatococcus, we should think about STAT3 hyper IgE syndrome or Diop syndrome. And in the case of thrombocytopenia, especially in boys, we should think about Scott-Aldrich syndrome. Hyper IgE scoring system may be also useful. And if we have suspicion for hyper IgE syndrome, we should refer patient to specialized center. You should also remember about a large number of primary immunodeficiency that associated with allergic-like manifestations. And allergic-like manifestations include urticaria, rash, and these symptoms is characterized autoinflammatory disorders such as some cryopyrin-associated disorder, Maxwell-Wells syndrome, familiar called syndrome, Nomet-Osinka syndrome, and other syndromes such as Traps, Blau syndrome, and a large number of other autoinflammatory disorders. All these disorders are characterized by rash and fever. On the other hand, there is a group of complement deficiency and C1 inhibitor deficiency. And for this disorder or hereditary angioedema is characteristic angioedema, but cryopyrin-associated periodic syndrome and in patients with autoinflammatory disorders is characterized by deficit of cryopyrin that lead to leukocyte apoptosis, interleukin-1 processing, and rash in this patient is caused by neutrophilic infiltrate in the dermis. In the case of C1 inhibitor deficiency, we have high production of bradykinin that leads to angioedema. But histamine and other mast cell mediators, as we see in patients with allergic manifestation, are not directly involved in this patient. That's why antihistamines are not effective for these patients. The treatment approaches include general treatment strategies for primary immunodeficiency and treatments for allergy symptoms. General treatment strategies for primary immunodeficiency consist of antibiotics, intravenous or subcutaneous immunoglobulins, for example, for Netherton syndrome, hematopoietic stem cell transplantation for some syndrome also, and gene therapy for Wiskott-Aldrich syndrome, IPEC syndrome, open syndrome. Treatment of allergy syndromes include corticosteroids, topical or systemic, local application of calcineurin inhibitors, tacrolimus or pimecrolimus. Though primary immunodeficiency are often associated with viral, bacterial, and candida infections, it is a challenge to treat atopic dermatitis and other allergic manifestation by means of this drug, considering their immunosuppressive action. These medications are not recommended for long-term use or treatment of large surface areas. Skin and other infections should be carefully examined. In cases of skin superinfection with Staphylococcus aureus in patients with PID and eczema, systemic antibiotics and antiseptic arrangements are used. Long-term use of emollients for skin may be useful in some primary immunodeficiency, such as Netherton syndrome, Wiskott-Aldrich syndrome. We also can use medication to control pruritus, and there are some publications about effective treatments of eczema by antibodies to immunoglobulin E omalizumab. Very important is a team approach. We should join the skill of the immunologists, allergists with other specialists. The main take-home messages. Allergic manifestations are one of the clinical signs of primary immunodeficiency. Usually, they present in the first year of life among the first symptoms of primary immunodeficiency and are commonly manifested by eczema and increased IgE. There is usually no correlation between IgE levels and severity of allergic skin manifestation. Often, the skin barrier function is not impaired in patients with eczema and primary immunodeficiency. Early differentiation of allergic manifestation due to PID from atopic dermatitis and other atopic conditions is very difficult. Also, it is very important because it influences on the choice of treatment methods. And a multidisciplinary approach to the management of PID patients and prescription of appropriate treatment improves the prognosis and quality of life of PID patients. Thank you for your attention. Welcome to Ukraine. Welcome to Ternopil.
Thanks again, Professor Boyarchuk. It was so informative, so spectacular and great presentation. We learned a lot. And to our dearest audience, please feel free to ask questions in the chat section. Now it's time to ask Professor Alireza Ranjbar to join us in his speech on molecular pediatrics in context of clinical pediatrics today and tomorrow. Professor Ranjbar, we are all with you.
Dear colleagues and friends, I am very pleased and honored to participate in this prestigious International Congress of Pediatrics, which has been organized by the Tehran University of Medical Sciences. I would like to express my best thanks to Chairman and members of Executive Board for their kind invitation. I will try in the next 30 minutes to present some aspects of the increasing role of molecular pediatrics in clinical pediatrics. Rudolf Virchow published a concept in which the origin of diseases should be found in error of cellular function. Paul Ehrlich expanded the approach of cellular and molecular levels, his perception of substances which react specifically with microorganisms of the body's own cells through of specific receptors introduced the beginning of molecular-orientated therapy. The Max Delbrück's work about the nature of gene mutation and gene structure was the base of modern molecular genetics and molecular biology. The development of modern cellular and molecular biology will lead in next years to paradigm change in diagnostic and therapy as well as in prevention of diseases. The use of molecular approach gives us the opportunity to explain the function of each cell and of particular cellular components and to understand the mechanisms and rules of their interactions in tissues and organs. By understanding of these biological processes, the possibility arises for rational and specific therapy as opposed to up to now mostly symptomatic approach. I would like to present some cases in the different fields of pediatric. As an example, asthma. The heterogeneity of asthma in relation to patients' characteristics, so-called phenotype, underlying pathogenic mechanisms, so-called endotype, and clinically significant outcomes, including response to treatment, has been established beyond any doubt. We know two endotypes of asthma. Firstly, the type 2 immune response, in which we observe a predominance of cytokines such interleukin-4, interleukin-5, interleukin-13, and presence of eosinophils and IgE-mediated allergy. Secondly, the non-type 2 response with predominance of neutrophils and presence of neutrophilic inflammation with cytokines such interleukin-8, interleukin-23, interferon gamma, and tumor necrosis factor alpha. But there are another endotypes which have not been described previously. I would like to present one case. 2-year-old child came to our clinic with massive bronchial obstruction and pronounced wheezing. His mother has inhaled the child several times with salbutamol, ipratropium, gave him rectally prednisolone, but without success. You can hear the wheezing without auscultation. We came to the examination room and the child has begun to cry. It is a cry of body and soul. During the cry, the wheezing has been disappeared. No wheezing more after the crying, but it was a cry of body and soul without medication. It is after 10 minutes, no wheezing, sustained symptom-free status. And it is after 30 minutes. We have studied the reason of this phenomenon, and we have found a problem at the level of neuropeptides. We have demonstrated and detected a decrease of VIP, of vasoactive intestinal peptide, and the increase of substance P and neuropenin A. With other words, it was a disbalance between the neuropeptides, which act as bronchodilator, and the neuropeptides, which act as bronchoconstrictor. After crying, it was a simulation, and we could observe the increase of the VIP, and we think on the base of this increase, the child has were symptom-free. Another case. A patient with treatment-resistant chronic urticaria for more than 1 year. All immunologic and allergic examinations were without pathological findings. All autoantibodies were negative, and the test for Helicobacter pylori was negative. This patient has been treated with high-dose antihistamines and local and systemic corticosteroids, but without success. We have examined the IgE receptor and found an increase of IgE receptor compared to healthy control. We have treated this patient with omalizumab, and you can see this appearance of urticaria after 2 weeks, only with 1 injection. We have continued the therapy with omalizumab over 6 months, and we could detect a sustained reduction of IgE receptors parallel to clinical improvement. It is another case. It's a patient with recurrent treatment-resistant nasal polyps. The patient underwent several times surgical measures, but without access. And we have found high IgE receptors in nasal polyps tissues, and we have treated this patient with omalizumab, and it is the result after 2 months. There are several polypoid changes and an abstraction of ostomeatal complex. It is after therapy, and you see an improvement in all area. Parallel to clinical and radiologic improvement, we have observed downregulation of IgE receptors on basophils. Another aspect, and it's a clinical application of molecular medicine in neurologic disorders in pediatrics. The GNAO1 associated infantile epileptic encephalopathy is a rare disease with mutations in the guanine nucleotide binding protein, alpha activating activity polypeptidase O. It is characterized by early onset epileptic encephalopathy, severe involuntary movements and tractable seizures, severe motor developmental delay, and severe intellectual disability. Patients with GNAO1 mutations can present a severe progressive hyperkinetic movement disorder with prolonged life-threatening exacerbations which are refractory to most antidystonic and anticonvulsive medications and can lead to multi-organ failure and even to death. This is a patient with this mutation. The patient has been treated with current, with all current on off-label anticonvulsive medications, but without success. It's the same patient. It is after clonazepam, diazepam and chloral dihydrate, but we could not control the movement disorders. I would like to present another patient with the same mutation, and this patient is now 15 years old. I have diagnosed the mutation at the age of 6 years, and because of the very difficult condition of this child, we have performed an innovative therapy for the first time in collaboration with our neurosurgeon in Cologne. Deep brain stimulation of the globus pallidus internus acts through multifactorial mechanisms, including immediate neuromodulatory effects, synaptic plasticity, and long-term neuronal reorganization. And this is the patient after deep brain stimulation. no seizure, no movement disorders, no medications, and a significant improvement of motoric ability. Next case. This is a patient with atypical Rett syndrome, with a pronounced convulsion, and it was refractory to therapy with muscle hypotonia, psychosomatic retardation, and mental retardation. It was the condition of this child. No chewing ability. We have treated this patient on the basis of molecular medicine, molecular pediatrics, and this is the result. You have seen improvement all levels, cognition, muscle force, and motoric. And this child was able to walk after therapy. Dear colleagues and friends, I hope I could demonstrate some eminent role of molecular pediatrics in context of clinical pediatrics. Thank you very much for your attention.
Professor Alireza Ranjbar, thank you very much for your educational, spectacular presentation, and we learned a lot from your experiences and your lecture. The audiences did not have any question to ask you. I wanted to thank you again. From each and every one of us here at Children's Medical Center, Tehran University of Medical Sciences, we would like to say a particular thank you to Professor Rezaei, Professor Ranjbar, Professor Boyarchuk, and Professor Mahdavinia, whose support we are honored to have. And despite the time difference, we are more than happy to get involved. A special thank you also goes to all fantastic audiences. If you want to receive it, and again, it is worth mentioning that if you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panel. For our Iranian audience, if you want to receive a CME credit, don't forget to participate in the panel quiz in maximum of 2 days in the cmequiz.ir. Don't forget to follow us on our social media pages and our YouTube channel to stay updated on our next events. As I informed, there are some questions. It would be appreciated if Professor Ranjbar answered that. How did you treat Rett syndrome? Professor Ranjbar, if you're online, it would be appreciated to answer this question. Dear Professor. As it seems, Professor Ranjbar, thank you. We are calling him. It would be appreciated if you just be a little patient. It seems that some technical problem has occurred. Dr. Oksana is calling him by phone and asking your question by phone. It seems that there are some problem with his internet, and we are asking him and answer you here. And we are broadcasting his voice by here, if it is possible. Dr. Oksana will discuss your question.
Sorry, I just talked to Professor Ranjbar, and there was a technical problem that he cannot be with us with the up to the end of the session. And I just asked him about the treatment of the patient with the Rett syndrome, and he just told me that it will be published soon, and you can enjoy the publication. So thank you all, and thank you for joining us. Thank you for participating in this session, and I hope you have enjoyed the session. Azin.
Thank you, Dr. Oksana, for your great answer to us. Again, if you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panel. For our Iranian audience, if you want to receive the CME credit, don't forget to participate in the panel quiz in maximum of 2 days on cmequiz.ir. Don't forget to follow us on social media pages and YouTube channel to stay updated on our next events. And unless there are any other questions, I want to thank you everyone who has participated on today's call. Thank you for your patience. We look forward to seeing you at this meeting, and you're sure you will find it out an outstanding educational opportunity. Again, thank you everyone for your patience. We appreciate your continued cooperation with us. Please submit your questions to us on our social media. And if you have anything as that you thought of after conclude today's session, we will make sure to answer those questions. Thank you everyone, and have a nice time. Take care of yourself. Good afternoon. Bye-bye. Bye-bye.